Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hi, I'm Pat Loehrer. I'm Director of the Centers for Global Health and Health Equity at Indiana University Simon Cancer Center.
And I'm Dave Johnson. I'm a medical oncologist at UT Southwestern in Dallas, Texas.
Well, welcome back to ASCO's Education new podcast series entitled Oncology, Etc. Today, we'll be joined by two outstanding guests, Dr. Bryan Schneider and Dr. Adrian Gardner. We're going to do a deep dive about COVID-19. And Dave, I was thinking, as reflecting on my life, the thing in medicine is when new diseases come out. So, in our earlier lives when we started, there was no such thing as Lyme disease, HIV, AIDS, tumors didn't exist. And then just in the last couple of years now, we have COVID-19, the SARS-CoV-2. And I think as physicians, it's kind of exciting. What's your experience been with the COVID-19 on the wards at Parkland?
Well, it's been really very challenging. I don't know that the public yet has fully grasped the magnitude of this disease. 700,000 plus Americans have died of this disease. That's an astonishing number when you think about it. Now, I was just on the general medical wards a couple of weeks ago with a wonderful team of residents and students. Patients with this disease are very sick. We often downplay it, but I'm telling you, these people are really quite ill and can get ill and symptomatic rapidly within hours. So this is a serious illness, but I agree with you. One of the things I told the residents a year ago was to keep a journal, that there are few times during the course of your training and career where a new disease emerges and you can be part and parcel of that. And keeping a diary of what happened is something that I wish I had done when AIDS emerged back in the 80s, or other disease processes like Lyme, as you mentioned.
And syphilis for you, wasn't it?
Well, that was sort of a Hippocratic oath days, but yeah, no, I think that was, I can't remember. We were hanging out together at the time, so I don't remember exactly. Yeah, no, it's been really remarkable. The thing that's been interesting to me is the response of individuals and their families to the disease, particularly once the vaccines came available. So maybe we can delve into that a little bit today, because I know one of our guests has actually experienced that himself. So we'll know more about it later.
I don't think, to be honest, that we could have a better collective wisdom than we have today with Dr. Schneider and Dr. Gardner, who will talk about their personal and professional, and I think the global impact of COVID. I don't think there's any two people better than that. The only thing we could do better is if Anthony Fauci was here by himself. But these guys are tremendous people. Dr. Gardner went to medical school at Brown, did his fellowship in infectious disease at Beth Israel, and then did his MPH at Harvard, and joined the faculty at Indiana University in 2012. When he was a student, he spent time in Kenya with Joe Mamlin from Indiana University as part of the AMPATH program, and he came back to become the field director there. And he is just an outstanding person. He's now the director of the Center of Global Health for Indiana University and the Associate Dean for Global Health, and has led the contact tracing for Indiana University. And he's going to give us some input from this. Bryan, again, I've known forever, is just an outstanding medical oncologist. He is now professor of medicine and medical and molecular genetics here at IU. He's a Vera Bradley Chair of Oncology. He is the founding chair of our Precision Genomics program, and just a superstar in breast cancer as well as pharmacogenomics, and was one of the first to describe the unique neuropathy associated with the taxanes in breast cancer. So it's just a pleasure to have both of you here.
Pat, it's great to have that talent there. It balances out the negativity of other faculty members, but that's great. Welcome, both of you.
I loved you a minute ago. I turned mute on from a distance here. Adrian, tell me a little bit about yourself growing up and how you got to where you were.
Sure. Thanks. And thanks so much for the invitation and, for being part of this and for the generous introduction. So as you said, Pat, I'm a product of an international environment. That's been an important part of my upbringing. Actually, I was born in Scotland to two parents that are, born and bred in Scotland and grew up in Scotland. Spent the first 6 years of my life really living in France, and then moved to Lawrence, Kansas, which was quite a culture shift, but spent 4 years there. And it was great actually time in my life to be there before moving to the East Coast, where I went to, sort of school and did all my medical training. So I'd had international experiences before, and I think that was an important part of my upbringing and something I've sort of sought for my kids, and in the sense that it sort of, just immediately resets your kind of sense of the world and makes you sort of feel like a global citizen as opposed to just sort of more limited kind of the community you're surrounded by. But it really wasn't until my experience as a fourth year medical student at Brown that I had the opportunity to sort of see healthcare in a low resource setting and sort of, see that. And that was a very powerful experience professionally and personally. And as you said, it was the time when Joe Mamlin was really just dreaming up what the HIV response was going to look like, and sort of this nice institutional partnership that we'd set up in Western Kenya. But we set it up in the middle of a global pandemic, and true to our mission of sort of responding and leading with care, felt a need to respond to the HIV pandemic. And that started really it was motivated by personal interactions that Joe had with some individuals who he saw firsthand come back to life, the sort of Lazarus effect that has been reported. And that really spawned kind of this whole, response, changed my career and certainly my life, and, had profound effects on my life. So that's a bit of who I am as an individual and how I got to where I am today.
Yeah, we're going to touch on some of the work that you're doing now. But before I do, Bryan, tell us a little bit about you and your background, where you grew up and how you got to where you are today.
Thanks to you and Dave as well for having me on. And this will be an interesting perspective because I think I'm kind of coming on here as the patient this time. So it'll be a different view. But in contradistinction to Adrian, I am a pure Hoosier. I was born in the southern part of the state and raised there, and then drove 3 hours north to Indianapolis, where I've set up for the last 25 years. And, just been really lucky to be here at Indiana University. And Pat, you may not even remember this. About 25 years ago, you were my formal mentor for med school. And so one of the influences in sticking around here, along with some other real greats along the way. So have done, as you mentioned, breast medical oncology here in genomics, and have had an absolute blast. So thanks for having me on.
Oh, we love having you. And just as an aside, Bryan, one is, I think, the world of you and so proud of what you've accomplished. But Bryan's backyard actually was the home of Henry Lynch, and where he first described Lynch syndrome out in southern Indiana. And I think no greater tribute than his legacy than what you have done with precision genomics. It's really terrific.
Yeah, maybe we'll have some time to delve into that. But actually, I'm curious, Bryan, you mentioned that you've come on as the patient. My understanding is you've had firsthand experience with COVID, not just as a physician, but as the recipient of that wonderful new virus. Maybe you could tell us a little about that.
Yeah, an interesting experience to be sure. So about 2.5 months ago, I tested positive for COVID and got really sick. Yeah, my 3-year-old son had brought it home from his preschool and infected his older brother, who's almost 12, and then my wife and myself. And so, it was a really fascinating experience, I guess, and brought about some aspects to the virus that I had never really thought about.
Now, Bryan, you also had COVID before, too.
Yes. And, the first time I was probably one of the very, very early cases, and got really sick with it and lost my sense of taste and smell. I actually got one of the purple fingers, which I went to the ER for. I thought I was having a clot or something. And at the time, those weren't well-recognized symptoms. And that loss of taste and smell went months for me. So, yeah, I think I have frankly had the infection twice. The second time, though, was documented and certainly got really sick with the second one.
Can you elaborate on your second case? When you say you got really sick, was it a respiratory illness or were there other symptoms?
Yeah, there were two aspects to it that were kind of interesting. I think the first was physical. I got a sense of fatigue that I don't know that I have ever experienced before. it was one that I literally just could not get out of bed. And, I lost about 10 to 15 pounds from just being anorectic. And I'm not an overly thick human being to begin with. But the big one was shortness of breath. And, we had a pulse ox at home. My wife's a pediatrician, and I was sitting in the high 80s. And, I work out 5 or 6 times a week, so keep in pretty good shape. And I was stopping midway up the stairs to sit down because I felt really tachycardic and just lightheaded. And so that degree of physical punishment is something like I have never expected or felt before. But, the psychological part of it was really something I did not expect. And, one part of that was an odd sense of guilt. I was getting, texts and calls from a lot of friends checking on me, and many were baffled and, asking, hey, did you not get vaccinated? Or, what was going on with that? And so that it was a very odd sensation to me because I, of course, been vaccinated and I mask and all those sort of things. The other was one of real fear. I worried, luckily, I guess our family all got infected around the same time, so we didn't have to think about quarantine. But I started wondering, could I have infected a patient, take care of immunosuppressed breast cancer patients before I was symptomatic? And then even after I came back to work, I had quarantined for quite some time, but I was really fearful. I would find myself double masking, washing my hands incessantly, and even holding my breath when I was trying to listen to heart and lungs during examination. So that sort of psychology was something I don't think I really expected with this infection.
How long did it take you to get beyond that, or are you beyond that part?
Yeah, I feel back to kind of my baseline now, and I certainly don't worry about it on a day-to-day basis now. But my first clinic or two back was really hard for me psychologically and emotionally. And, part of me even wondered, should I profess to all my patients that I've had COVID, or what things can I do to help protect them? And again, it was that kind of mental aspect that I just didn't really anticipate prior to heading back to my clinic.
This is eerily reminiscent of the physician who's had cancer, who experiences extreme fatigue for the first time, chemotherapy-induced fatigue, after having described it many, many times before.
Right.
And who has a guilt sensation of many respects as well. So quite the experience for sure.
Dave is talking about himself, by the way.
No, I can only imagine. And you're right. We do try to paint a picture to patients about how things are going to feel. And it's amazing when it's internalized or when you're feeling it. It can often bring about a sense of, wow, I don't know that I may have underplayed this to some of my patients in the past. And it really does provide some degree of empathy that's hard to capture if you haven't felt it.
So when I was on the wards, Bryan, I must confess there were times when we walked into a patient's room with COVID who, of course, had not been vaccinated long after vaccines were approved. Our professionalism prevents us from doing anything other than taking care of those. So I'm wondering how you feel about caring for patients who have not been vaccinated or refused to be vaccinated.
Yeah, I think probably similar to a lot of people listening here today, it's a bit frustrating. And, I think we all take care of patients who, have a really tough diagnosis. And we're in the interesting field of giving patients medications that really immunosuppresses them. So we spend time counseling on the fact you may get really sick or hospitalized or even die from neutropenic sepsis. And I think that is something that rests really hard with patients who are already dealing with a life-threatening diagnosis. And so now trying to do that counseling in the face of a global pandemic like we haven't seen for 100 years has really brought around, a sense of duress and distress in my patients like I've never seen before. I even had a patient who moved away from her family to be quarantined during adjuvant therapy, which I, of course, recommended against. But it really impressed upon me how big a deal this was. And so to see their frustration and then, in contradistinction, understanding that some people didn't want to kind of pitch in to help, it was very frustrating and honestly just made me very sad for people who I know were really struggling with this.
Actually, I have one more question to ask you. You mentioned coming back. Did you, in fact, share your diagnosis with your patients? When I had cancer and came back, I made a sort of a pact with myself that I wasn't going to do that. But then I learned that the nurses were telling patients that I had cancer. And I found out it actually was helpful to share that diagnosis with many of my patients so that they could ask questions and feel that they had someone who really had experienced what they were either going through or about to go through. So I'm wondering how you've shared your diagnosis of COVID with patients, if at all.
No, it's a great question. And I may have followed a similar pattern. At first, I didn't. I didn't know what to do, to be frank. I didn't know if my saying that would make that patient in that moment more stressed out or worried. And I certainly didn't want to add to that. So, I took it upon myself to try to make myself as safe to them as possible. But now that I've had a little chance to reflect on it, I have shared it. And I think for some of my patients, it's been good for them to kind of hear what that experience was like. I think it's also, Dave, as you probably know, I think it also reminds them we're human too. And we experience some difficulty with physical health. And I think in some ways it allows us to bond in a little bit deeper way.
I agree.
I want to turn the attention a little bit to Adrian. Now, Adrian, you're in a unique position, obviously, one, because of your experience in Kenya, and we want to hear about that, but also your responsibility for Indiana University. What some of the listeners may recall is that there was a decision made that you were part of to actually mandated that students at Indiana University be required to have vaccination before they came to school. We were in Kenya at the time when we heard that there was some reconsideration about that from the state legislature in terms of how mandating that. And eventually this was a case in which 8 students took this case to court that eventually reached to Amy Coney Barrett, who decided to find in favor of Indiana University. It was a landmark decision here. But tell us a little bit about your experience on the leadership role of COVID and the impact that you see in terms of yourself personally and from the field of the university.
Yeah, thanks, Pat. I think it's really a sort of 2 different worlds in my mind in some ways, although clearly linked by this, global pandemic. I was just finishing my 8-year stint essentially in Kenya in March of 2020, when we sort of got the news that, the entire world was about to be declared a level 4 by the State Department. And I remember actually talking to Joe Scodro on the phone. He's like, what the heck does that mean? That's not in our playbook of what we do when, things happen and we need to bring trainees home and sort of.
Scodro being the lead counsel for Indiana University here.
Thank you. Yeah. So, for me, obviously I was making a transition back to a US-based career in this position as the director for the Center for Global Health. But, I had a dramatic change in my position, right? Who was going to do global health operations in the middle of a pandemic? Well, nobody, because nobody was traveling. So we had really shifted all of our Kenya operations to sort of a virtual support. We pulled all our trainees and long-term faculty back initially. And my own position here sort of got pulled into a leadership role in Indiana University's response to the pandemic, along with sort of 3 other, physician leaders. And we all sort of took on a different component of the response. So I was involved in the contact tracing, in part because we had some experience with contact tracing in global settings and tuberculosis and HIV. And while the transmission dynamics are obviously quite dramatically different and sort of has different implications, that some of the principles around contact tracing were similar in the sense that contact tracing is not about, really a stick. It's more about, extending a carrot and extending the support that allows you then to create an enabling environment in a quick phone call, in this case, to allow people to identify what it is to quarantine and isolate effectively. To get to the Supreme Court issues and around mandates, I think it was fairly obvious. So we were part of a restart committee that had been put together by the Dean of the School of Medicine, Jay Hess, and it was fairly non-controversial among that group that we were going to need vaccine. As we marched through this and sort of, we immediately sort of set up a lot of testing infrastructure and what we called mitigation testing at that point of asymptomatic individuals, in addition to sort of creating systems that enable people with symptoms to enable testing very quickly and to get results back and to get that whole infrastructure, in place. But it was pretty obvious to us as a group of medical, public health, and ethics and legal folks that we were going to need a high level of immunity to get back to anything normal, right? And as we began planning for the summer and the fall of 2021, it was kind of a no-brainer. The only way you're going to get high levels of immunity, if you want to bring people back into the same classroom, if you want to, have people living in dormitories, if you want to have them engaged in the normal activities that college kids want to engage in, then you got to have a very high level of immunity. And the only way to really achieve that is going to be through vaccine mandates. And Again, didn't feel like unprecedented because you have to get a whole bunch of vaccines when you go off to college or when you go off to elementary school. And that's really the only way to achieve that high level of coverage that allows us to not have, a bunch of measles in our environment. And, we still have mumps despite high levels of coverage. But yeah, it sort of felt weirdly non-controversial. But of course, like the whole politicization, I think, of the whole, response to the pandemic, made this more controversial. And clearly there are people that feel very strongly about it. But I think this framing it in a context of sort of personal freedom versus public good has not been particularly healthy for us as a country. I guess I'm not terribly surprised that, the Supreme Court ultimately ruled against the preliminary injunction. I think the formal case is still sort of pending, but it's sort of maybe been overtaken by events, because now there are, government mandates that are requiring vaccine or regular testing of just about, lots of different industries and government employees and things. So I think it was important that we took a stand on this. I think it has set a precedent, I think, for other universities. There were initially some hospital systems doing the same, but I think it's made it a lot easier to keep moving through, industries and health systems with this kind of decision.
Parenthetically, there's this week they announced we reached over 1 million cases of COVID in Indiana. But the lowest county for infectious rate is actually Monroe County, which is where Bloomington is, or where Indiana University is, and it's less than half of the rate of the state. And so I think kudos to you and the staff that have done this. Just maybe briefly, could you reflect on your experiences in Kenya, here in the United States, lessons learned by you or by the university or by public officials about the contrast? I am reflecting now about a patient I saw today that we're talking about the booster vaccine, and unfortunately, in Kenya, most people haven't gotten their first vaccine either. So reflect a little bit about the global impact as you've seen personally.
Yeah. So I think, it's felt like two different worlds, but obviously so struggling with the same thing, right? So, I think on a global perspective, so Kenya got off to a pretty good start because they were kind of late to the game when it came to COVID. And they were able to jump on and learn from some of the lessons about physical distancing and shutting things down that actually enabled them to escape in the beginning. Of course, there's probably transmission going on behind the scenes that we sort of weren't detecting. And even till now, the numbers that are officially reported are really just the tip of the iceberg. I think we know that. Kenya's only reported, 250,000 cases and just over 5,000 fatalities nationwide since the beginning of the pandemic. But there are serology studies that suggest that, 50-60% of the population may have actually been infected at least. Right. And that's based on blood donor studies and things. So, I think some of the initial challenges, obviously, around access to PPE, as we think about healthcare settings there, which our partnership is based in, as you know, just the lack of infection control and the ability to even think about infection control because you're lacking space. As you know, Pat, in many of these wards and low resource settings, there are 2 patients in every bed. And one might have active pulmonary TB and one might be getting chemotherapy for breast cancer. And it's less than ideal. But as you think about how to respond to that, it's pretty hard when you don't have any space, right? We did a lot here in terms of retooling space and utilizing space that was not being used and putting in negative pressure rooms where they were needed and this kind of thing that just weren't options in Kenya. One good news was that, I think in Kenya in particular, the testing capacity was able to get an early jump because the HIV infrastructure, PEPFAR, the President's Emergency Plan for AIDS Relief, had established 7 regional laboratories that were obviously running HIV viral loads and so had PCR platforms. And they were able to rapidly retool those and convert them into COVID testing laboratories for PCR. So that was good, but then never really got to the same point where we need to get to, which is that it's readily accessible to everyone in rural regions and rapid testing in order to inform sort of triage protocols and for inpatients and try to figure out how to develop that. So there's been testing available, but just not in the quantities that were sufficient. I think we've been able to work across virtual platforms to share knowledge about management and clinical protocol development. That's been another, success story. Certainly our partnership is longstanding, and so has allowed those relationships have withstood the test of, non-personal interaction. And of course, the biggest, sort of elephant in the room now is this issue of vaccine equity, as you pointed out. So, about 5% of the population in Kenya has been vaccinated. Part of that is vaccine access. Part of it is probably distribution infrastructure. Think about low resource settings. Many of them do quite well with vaccine delivery, but they're early childhood vaccines, right? So they have an whole infrastructure around maternal child health that's kind of set up to do this. There's not a lot of infrastructure for rapidly mobilizing 50 million adults to try and get them in for a 2-shot series So how do you do that? I mean, yes, there are some community assets in terms of community health workers and things, but so far, at least, the vaccine quantities available have not been sufficient to allow that kind of infrastructure to really take over, at least in Kenya. But it holds promise, I think. But then it also sort of up against the same, I think, some of the same challenges that we face here in terms of vaccine misinformation and, lack of trust. This is an area where I think, trust is really sort of a key ingredient in health systems. And I think we've seen it in our own inequalities that have been sort of made very, very obvious in our own country, and really the issue globally. And it's not a new lesson. We knew it from Ebola and other very obvious infectious diseases that have resulted in high degrees of death because of lack of trust. When I have taken care of patients here, and I've had those same sort of experiences that Dave was talking about earlier, where you sort of want to just ask the patient, so why didn't you get vaccinated? As an infectious disease provider, we've been called into a lot of these cases, and I've taken the opportunity to ask a couple of times, not in a judgmental way, but trying to sort of set the stage and just, what is it about the system? And some of it is misinformation. Some of it is, sort of this politicization and political bias, but some of it is just sort of a very kind of subtle mistrust, and this notion that you don't feel completely welcomed or respected within the healthcare setting. And that's enough to just sort of turn it off to this point where I'm just not ready to do that. And I think that's sometimes more subtle than we appreciate, but it has a huge impact.
We're getting close to the end of our time. I want to pivot back, if I may, just for a quick moment to Bryan. This may be an from left field type of question, but we learned a lot about early chemotherapy from the infectious disease world. We sort of took some of the infectious disease principles and applied them in the early years of chemotherapy. Do you think there's much to be learned from a precision medicine standpoint from the COVID pandemic? What are you taking away from not just your personal experience, but the larger experience, if anything? Or is it just too early to say?
No, I mean, I think I've always admired the speed and efficiency with which breakthroughs have happened in infectious disease. And I mean, the idea of a brand new virus coming on board a couple of years ago and coming to the point where we are today shows, I think real innovation, but the ability to get behind a question and as a community answer it well. And I think from that standpoint, that's something that all disciplines, including oncology, can learn. I certainly think we're seeing more and more intersection too with the way we think about treating cancer and its impact on immunity. And so certainly in that way, I think there's real connections. But I do think some of the innovations that were brought about from the NCI with the vaccines are going to really also herald in things that'll be game changers in the world of oncology and therapeutics as well.
That's great.
If I can throw in something too, I think, Dave, particularly as we talk about global health, many of the cancers that we see in the low to middle income countries are caused by viruses. One of the number one causes of cancer in sub-Saharan Africa is cervical cancer. We could eradicate that by getting vaccines out there. In terms of the lessons learned, I think the lessons learned in oncology that we need to deal more with population health and with prevention than we do with the treatment towards the end of the life. And hopefully that'll be a lesson that we can take home with us around the world.
Yeah. And Pat, I think, we do need to do better as a global community in terms of sharing vaccine and, get manufacturing up, and not just for vaccines, but PPE and therapeutics. It's just not fair, the world we live in now. And I mean, I think we all know that, and we sort of take it for granted in some ways, but it shouldn't be this unfair, right? And that's been part of the problem globally, and it's part of the problem in the United States.
Yeah.
But the tail end also is access to drugs for chemotherapy too, and they have radiation available for all these patients. So it is this access is an important part of health equity globally. And I think it behooves all of us to be involved with this mission.
Well, again, we've come to the end of our time, and we want to thank all of our listeners, but most of all, we really want to thank Bryan and Adrian for a wonderful interview. We really appreciate your time and your sharing your experiences with us. Thanks again to the listeners for tuning in to Oncology, Etc. This is an ASCO educational podcast. We want to talk really about anything and everything. So if you have an idea for a topic or a guest, we invite you to share that with us and email us at education@asco.org. So thanks again. And remember, Pat, I before E, except after C.
Well, see you later then.
Well, wait a minute. 8, leisure, sovereign, wait, weird, foreign, vain, neighbor. Apparently it doesn't work. My second grade teacher taught me that rule, and it's just wrong.
Thank you for listening to this week's episode. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org.